Yeah, so this is the Real Rare Club over here today, and I'm not sure, do we have any particular diseases that are represented amongst the attendees that are?
Neurosarcoidosis.
Okay, okay.
Dr. Clardy is my doctor.
Okay, good. Yeah, you're in the right hands, but Dr. Zhang and Dr. Kadish are also here to help us. Any other disorders? Unknown diseases of uncertain etiology are all welcome here today.
In progress.
Yeah, and so I think we have a group of patients that may be misunderstood.
When you're late to class, you're in the front. It was too chatty.
Yeah, maybe.
Actually, there's more of you. And you'll find this out on the patient panels. So.
Yeah. So maybe, well, people may be coming in, but maybe we can talk about neurosarcoidosis as the first disorder.
Just make sure anytime you guys are talking, just make sure you get that microphone. Because, I mean, it picks it up. But
Yeah.
I'm getting you good, but anybody else?
Okay, great, yeah. So neurosarcoidosis, it's a disorder that can cause quite a lot of difficulties. Were there any particular aspects that were of importance to you?
I just want to be better.
Okay.
I'm tired of being ill.
Okay. I think that's the problem with these disorders, as they were mentioning earlier today, that there can be quite a few commonalities amongst the disorders, and a lot of it is you don't feel well because of, spasms, pain, discomforts, headaches, all these kind of things. So how are we going to make her better, Dr. Clardy?
Oh my goodness. No, I think this is, many of you know, and probably a lot of the people in the room, I know, if not all of you, in the last 12 years since I've been here, since I joined John, and then you may not know this, we actually have the largest autoimmune neurology group in the world at the University of Utah. And so some of you may see Robert, and you heard from Tammy Smith, Jonathan Galley's here. They're all scattered around. Many of you know Tracy, who is the sort of linchpin that holds everything together. Many of you recognize Addison and Jack from greeting you and rooming you, things like that. But as time has gone on, many of you I know because as we've developed treatments for NMO, as we're getting there with MOG, as we're getting there with the other conditions, I'm trying to sort of see more of the patients who don't have a home, who don't have a clear diagnosis, who in many cases have multiple diagnoses that are all supposed to be 1 in a million, and you're going, come on, how many lottery tickets did I buy, right? And so that's why we have a special session for you, because otherwise, who's your group, right? So this is your group, and this is a big group, and this is a long time to be in the, this is the best fit, even neurosarcoid may be the cleanest diagnosis we have in this room. Other people's granulomatous disease, it's immune deficiencies, it's all the things. This is where the frontier is. This is where I think the hope is. I think you're incredibly important, as we mentioned, because this is the rare of the rare, right? Many of you know I talk to you about NIH sometimes, about doing more diagnostics. For many of you, it's, I'm sure, exhausting to come see any of us because every time you come in, we're revisiting, right? Okay, do we have it right? Okay, what more have we learned? Can you please tell me about your second cousin once removed again? What did they have? Could it help us figure you out, right? So these are your people that actually truly understand that in this room. No one in this room has an FDA approved treatment for their condition.
Well, they have an FDA approved treatment. It's just not for your disease.
We beg, borrow, and steal these treatments from the other specialties. But I mean, I'll let you run it. Questions, any thoughts, any?
Okay. Well, are there any particular symptoms that are of importance for various folks right now? Could be spasms or neuropathy. And yeah. hmm And so these are common themes amongst these disorders. So, have you been able to see a urologist in terms of this? Yeah. So. Oh yeah. So keeping in good shape there. I hope making some progress. So, bladder conditions are amongst our most challenging issues because there can be different parts of the nervous system affecting the bladder, and so you end up with, 3 different types of bladder problems. And so the one is the most common that we see in the MS clinic is going to be the urgency and frequency. And so we have a fair number of medications to help that and Botox. But there's one that's a little challenging. That's the one where you have a bladder situation where you feel like you have to go urgently, but then when you get there, it won't go. And so they say that's a dysynergia or a desynchronization. So, and we have one medicine for that. But then the other one, the most serious one is where there's urinary retention, and that has to be dealt with either mechanically by draining the bladder or using a medication to help the bladder contract more. But that's certainly a difficult issue. Maybe I'll ask Dr. Kadish to weigh in on other symptom treatments that he's run into for various conditions. Yeah.
Absolutely. So neuropathy, another difficult one. Neuropathy can actually be because of a lot of different reasons. So frequently with the patients that I see, I make sure that there's no other condition going on in addition to, what we're seeing you for that day, because if there is, that's low-hanging fruit, right? So there could be potential low-hanging fruit of vitamin deficiency or something else that could really help that neuropathy and those zinging, zapping, burning, jolting, searing type pains. Unfortunately, these days we also have begged, borrowed, and stolen a lot of other medicines from other people, and we can use these for neuropathy as well. And so I find that sometimes it takes maybe 2 or 3 trials of meds, but sometimes maybe 4 or 5 different symptomatic meds. But we do get some really good benefit for the neuropathy. Oh, fatigue. Yep.
Oh, so on that line, this is a challenging area because, yeah, we have these medications. Often they're anti-epileptic drugs because they do control neurons and calm things down in the nervous system. And they can be very effective for neuropathies if they're painful particularly. So the problem with these drugs is you have to build them all up. You can't just take 2 pills and suddenly feel better. And so it's hard to do this. You have to remember you're going to build this medication up over time, and then we got to look at the side effects versus the benefits and see if another agent might be needed. And so, patients will often take 1 or 2 doses and then be disappointed, but that's not what you really need to be doing with these medications. So it's a little bit of a group effort and you may need to transfer from one group to another group and do a double crossover kind of thing. So that is pretty tricky. That's why we have a pharmacologist in our clinic. So, Dr. Zhang, do you want to tell them a little bit about spasms and spasticity from your point of view?
Sure. And you also mentioned fatigue as well. I think to touch upon fatigue, that's something we see in a lot of our patient population, multiple sclerosis, other neuroinflammatory disorders. And again, like Dr. Kadish said, I think it's really important to see if there are any other reasons for the fatigue, such as sleep apnea, certain vitamin deficiencies, and to make sure we get those under control first. And then we have some very good medications like modafinil that a lot of our patients have found very helpful. Some of our patients take it just as needed, so maybe during the weekdays and not on the weekends, in the morning, sometimes once in the afternoon, and they find a lot of benefit for that, for their fatigue. But first, I think it's really important to make make sure that if they're snoring at nighttime, we do a sleep study and make sure that they're on some sort of sleep apnea machine at home to take care of that. If they're vitamin D deficient, if they're anemic, that could contribute to fatigue. So getting all of those things under control first and making sure there's nothing else going on. In terms of spasms, that can also really affect patient quality, sleep quality, and in turn also contribute to fatigue as well. If you're in pain all day, you'd imagine you'd have a hard time getting through your day, you'd be fatigued, you'd have a hard time sleeping, which then kind of goes in a vicious circle and you'd have fatigue all the time. So it's really important for us as clinicians to treat spasms, and we have, again, a lot of different medications, such as baclofen, other medications as well, that we kind of will titrate to the level that the patient is at. Again, we started at a low dose, and maybe you're not getting the full benefit of that medication yet, but we work with you to titrate that dose up and up and up, like the neuropathic medications, to get you at a level where the medication is not causing you undue fatigue, but it's controlling the pain, so you get good quality of life during the day.
I have a question. With my wife, it's confusing to me because there's fatigue. So it's like bedtime at 8 and I'm done, you know, and that's hard. But I also wonder if like the brain fog, the cognitive fog, it comes if she's had neuropsych eval and no, there's no Alzheimer's and all that. And it's like she doesn't remember where her aunt lives for 30 years. You know what I mean? It's like that kind of stuff. I don't know if there's anything to do about it or what, maybe you could comment on it.
You know, I can talk a little bit. I do not have an answer for you. I'll talk. I'll get the conversation started. So, in conditions like multiple sclerosis, we do understand more about that than in conditions like NMO or sarcoid. On the very, very kind of microscopic level, neurotransmitter level, what exactly is happening to kind of cause some of these issues. We do know that in general in autoimmune disease that fatigue is very, very prevalent, So is there some common pathway, between all of these conditions? I think more research needs to be done on this for sure. I don't know, Dr. Clardy, if you have any thoughts about that.
No, I think we listen and we learn constantly from every patient, but brain fog and fatigue are probably the two that are the most common across all autoimmunity. Probably has to do with the ongoing inflammation. So even if we're knocking down the inflammation enough that it's not showing up on imaging, we're not getting rid of that underlying driver that gave the attacks in the first place. And those manifest most readily in fatigue, right? And as you all know, that's not the same as tired, right? You say fatigue to your friends and family, and they're like, go take a nap. And you're like, okay, but I might get an hour out of that. But this is not tired. This is fatigue. This is my whole body screaming like I'm inflamed, right? And brain fog goes with that. And the brain fog worsens when you ignore the other things or, because you're trying to live, right? You're trying to go about your life. So no, we don't know for sure. I mean, people have done studies. Yes, this inflammatory marker's up, all those kind of things. We know that, but that hasn't translated yet into really precise treatments. We have modafinil, thankfully, and John and I remember this well. Thankfully, we at least have modafinil now. It used to be called Provigil by brand name. For years, we couldn't get that for anyone. So exorbitantly expensive. And so that's actually nice to have in the toolbox now affordably. Some people use this in combination with different forms of sort of a pure caffeine, a green tea, a black coffee. As you all know, if you just use unclean caffeine, the snowball starts rolling down the hill too. So it's so customized to everyone, and it's customized not just to you, the individual, it's customized to your week. It's customized to your day, right? And the thing that we know is it's intrinsic to the autoimmunity. It's intrinsic to the attack that's going on. And so it's always there, and that's why we try to treat it symptomatically, primarily. And then we hope, and what some people experience is when the immunomodulation gets some aspects of that inflammation under control, sometimes the fatigue and the brain fog lift to some extent. Some of you know that you're going into a relapse or another attack because those precede it. And almost all of you, when we first meet you, you will tell us, I've really actually had a lot of fatigue for a year before any other identifiable symptom. Something was just off, right? And that's how all those pieces of data are how we've kind of figured out, oh, this is the process. This is the inflammation. And so anything we can do, like they said, so we're always all nagging you about getting a sleep study, and you're going, oh my gosh, right? So I have a little obstructive sleep apnea. You want me to put a little oxygen on it? So, I need another piece of equipment or something to do, because tired on top of fatigue is a pure disaster for cognition, right? So it's an art, right? It's an art, and we're useless without your feedback, which is why we constantly are asking the questions and trying to titrate and saying, stick with us. Might take 3 months of us playing with the dose here. Oh, maybe it's not going to work in the morning. Let's do it at lunch. But that's all driven by you and managing it. You have yours. You wanna give this to them?
Oh, yeah, I'll have my own microphone. So I'm going to nominate you for the first neurometeorologist for fog, taking care of fog. I think there is some hope for some of the agents, for fatigue, and so depending on the situation, like the Provigil and Nuvigil are drugs that help fatigue in multiple sclerosis patients that we see a fair amount. So those could be useful. There are a few other agents that some people like L-carnitine, just over-the-counter kind of thing that's helped occasional patients. I think it does raise the question of, is there a medication side effect too? And, so we may be treating you for your nerve pain with Neurontin, and it may be working well, but, number one and number two side effects are sort of brain fog and fatigue, that kind of thing. So it's a issue with, just trying to get your medication squared away. And when it comes to these fatigue medicines, Dr. Clardy was mentioning, timing can be really important. So we don't use the Provigil too late in the day. So you're going to have either a big dose in the morning or a divided dose, and experiment with that a little bit, see what's going to be best for you. I think we were touching on one area that I thought would be important to talk about, and that is when you have one autoimmune disease, do you get another one, or do your friends and relatives have autoimmunity? So what's the most number of autoimmune diseases in one patient you've seen?
6. And I don't count thyroid, because that's so common. That doesn't even enter the discussion. But right, and this is, we get it, right? And that is also why, we're checking your blood regularly. We're asking you to keep an eye on things. The other thing is, and we'll touch on this in one of the other breakouts, is just because you have complex, rare, autoinflammatory and neuroimmune conditions does not mean that you're immune to getting all the other common things too. High cholesterol, high blood pressure, conditions of aging, right? And so we're always thinking about that as well, and hopefully you are too. And so we will first look at, but I think as a patient, it is always important to go into every specialist, every physician visit, and not allow them to always point to your rare unicorn piece alone. You always have to say, but doc, could that just be separate? Could I just have high blood pressure? Could it, maybe it's not. Could I have another cause of this pain, right? This is a real danger that we see to your population, is that the blaring sign at the top of your chart that draws our eye as clinicians is this rare, unusual thing that's complex. And one of the dangers I've seen in patients is that you go to an urgent care and they see that and everything gets blamed on that, right? That is incredibly dangerous over your lifetime. So you always have to say, okay, it could be that, but could it also be that I'm just like someone else who walked in without that? And are we thinking about all the causes, right? That goes for diagnosis, new symptoms, but sort of also, workup, treatments, like, right? So that's just sort of occurred to me when you said that, because people, and we do too, we have a short visit. We're going to focus on the thing that you're coming to us as the specialist for, but we always need to take a step back, and maybe we need your help sometime, like, hey, but also, right? Did you get your mammogram? Did you get your colonoscopy? You don't get a free pass on those because you've already got the 1 in a million, right? I think that's so important. But yeah, I think 6 is the record. But again, it's a complex thing. That's why I like the term dysfunctional disimmunity. Several people in this room, your immune system doesn't work when it should, and it attacks when it shouldn't. And that's a really challenging rock and a hard place situation to be in, right? And you're certainly not alone in that, and we're learning more by the week about that, right?
So, Dr. Kadish, when we're in the clinic and we've got one of our patients coming in, and we just happen to get an anti-nuclear antibody test and it comes back really high, what do we do?
Wow. So, this is a very commonly ordered test, and the ANA, right. And so the medical community, there are quite a few in the community that might perceive that this test to automatically diagnose you with something, and it is a screening test, right? It has a purpose, but it cannot automatically diagnose you with things. In the whole picture, it has a piece. And so it depends. To answer the question here, it depends.
Yeah,
we do not neglect it, but we really need to think about how does it fit within the whole piece. How high is the number, for example, that we're looking at? How concentrated, so to speak?
And maybe if they got new symptoms like arthritis that they didn't have before.
Right.
Things of this sort.
So kind of putting it depending on the symptoms.
Yeah. So, I mean, it's sort of an interesting thing of autoimmunity. And I think another thing that a theme that we've been developing is, if you're getting an increased numbness in your legs, what could be going on there? And, is it a neuropathy? Is it something in the spinal cord? Did you get a lumbar disc herniation and it's going down one leg? So just like autoimmunity doesn't prevent other diseases. What do we think about clustering of autoimmune diseases in families, Dr. Zhang?
That's a great question. It's not an easy question, so I might have to defer to some of my fellow panelists, but and patients. So I am a neuroimmunology fellow. This is my first year of fellowship. I'm working with these amazing folks to learn more. And just in my short experience in clinic, if you ask anybody, any one of our patients in clinic, oh, what does your mother have? What does your father have? Tell me more about your extended family. A lot of our patients will say, my mom had lupus. We have a lot of family members with rheumatoid arthritis, Hashimoto's thyroiditis, type 1 diabetes. You just start noticing patterns in people's family of autoimmunity. And so at least that has been part of my experience. They might not have the same they might not have neurosarcoidosis or multiple sclerosis, but they have other autoimmunity in their immediate family or some of their more extended family.
Is there any questions about that, autoimmunity, or anything that crosses people's mind as we discuss that? Oh, Dr. Pascoe in the back row has a question.
Along the same line of that, I guess this
Mm-hmm.
but it's not autoimmune, but it is some kind of pattern.
Yeah, yeah.